We're back, as you might have guessed, and as we threatened. Um, I always have something I think about during the break that I want to tell you. But the thing I always remember to tell you after the break is what I also asked you before the break. And I said, did everybody hear me well and continuously in the first part? And I got a lot of yeses. So I don't have to ask that question. But there's something I have to tell you now about the second part. And I always say this, I probably say this 10 times a year. Uh, when you go to histopathology lab in the old days, you would get a box of slides, and maybe you would hope that they weren't broken. And you would also hope that nobody stole your microscope, or the bulb burned out, or you forgot the key. And these are all problems with looking at real slides, which some medical schools still have. But the worst part, the worst problem of not being online, being in that archaic situation, is that once you are looking through the microscope and you got these slides and you're supposed to find the things that you're supposed to find, you often don't have anybody to help you. And sometimes there's a lab assistant and he goes around, and that's what I did for a while. And they say, yeah, that's a gland, yeah, that's a pancreas, that's a duct. But you always hope that they can come and spend more time with you. And you usually find out that they're not spending much time with you as you like because they're talking to the pretty girls. Well, I don't blame them. But the big thing we have to deal with now, all of those problems are not going to be happening because we're going to be looking through my microscope with me, everybody at the same time learning. And this is what I do several times a year, although I am doing them less now that I am doing the reviews at the medical school. So, it's honesty time. Okay? This is something that you have to answer now. I'm assuming most of you are medical students or at least halfway through your medical training. And I want to know if the stuff that we talked about in the first half was too overwhelmingly difficult or something that you already knew. Okay? I think I should start out by asking you one question. If you have not had a histology course before, let me know. Just say no or yes for you, whether you had histology. And I'm seeing a no, I'm seeing a yes. Okay, for those of you who never had a histology course, you may have found that this was kind of difficult today. But I'm making a lot of assumptions that you remembered the basic structures of tissues. Okay? Now, thanks for being honest, because I'm going to ask again, if there's anybody that thought the first half I assumed too much of your knowledge for histology, let me know. It's possible that you left already, so not many people are going to say no. So every year I have to know that if I'm at the right level. Okay, now for me and all the pathologists, this is like easy stuff. But if you're never even went to medical school yet, you're going to be struggling with almost everything I said in the first half. But if you are in medical school, and especially if you had a histology course, then I think probably this was appropriate. Oh, good. I'm glad some people are saying that they recognize the slides. I appreciate that. Okay, so let's go into the lab now. What I'm going to do is take my little lab box over here of slides, and I'm going to let you see it. And these are glass slides, so be careful, don't break them. And I have about a bunch. If I may not do all of them, depending on how the time turns out and how I feel. If you're tired, if I'm tired, but I'm going to go through once again normal histology of, major organs, and they're arranged alphabetically, and you could probably figure out what they are. So if something says APPNL, this is probably a normal appendix. So let's look at a normal appendix. And I know from many years of experience that about 1 or 2 seconds after I see the slide, almost all of you can see it as well. So I'm going to ask you a question. I'm going to blow up this little follicle here in the submucosa of the appendix. And as soon as I blow it up, I want you to tell me, as soon as you see it, say now if you see it. Okay, I want you to say now again when you see me blow it up even more. As soon as you see this little area centrally blown up where you could see the cells, say now. Okay, so it's been probably no more than 2 seconds for most people. So let's go back down to our big picture. Let's quit looking at the leaves and let's start looking at the forest. You might remember the appendix is an accessory organ near the cecum. And like the rest of the GI tract, it has an outer connective tissue called the serosa. And then it has a muscularis, which is this muscular lining here. And then it happens to be the part of the GI tract in which the thickest part is actually the submucosa. And the submucosa is filled with all of these little follicles, lymphoid follicles. And then you have the inside, which is the mucosa. And when we blow it up, you're going to see epithelial cells. So forget about everything I said, but remember, every gastrointestinal organ has a mucosa near the lumen, and then a submucosa which has connective tissue, or in the case of the appendix, it has tons of lymphoid tissue. It might have fat, which is what you see here, and then it has a thick muscular layer. Just remember 4 parts. You don't have to remember the names of all the cells. So let's go to the part that we call the muscular layer. Well, it has blood vessels in the serosa. It has nice smooth muscle. And then I'm going to move it a little bit. It might be a couple seconds for you to see it, but you can see a nice lymphoid follicle. And then you can see these columnar epithelial cells in the mucosa and something called the lamina propria. But there's your lumen all the way down here. Then you have your mucosa, your submucosa, and then your muscularis, and then your serosa or connective tissue. Some cases you don't have a true serosa, you may just have connective tissue, which they call, I guess you call it adventitia, or connective tissue, let's call it. Now take a look at the muscular layer, which is usually the thickest layer in most of the gastrointestinal tubular organs. Let's take a look at that muscular layer. And it should be smooth muscle. And let's blow it up. I'm going to make a little box, and in about 2 seconds, you're going to see nice, normal, smooth muscle cells. If you cut these smooth muscle cells longitudinally, the nuclei look like hot dogs. If you cut this outer layer where the cells of the smooth muscle are now cross-section, or you're cutting them like you would a hot dog, they're going to look round. But let me ask you a question. Are all of these smooth muscle cells infiltrated or not infiltrated by inflammatory cells? And the answer is they're not infiltrated. Now let's go to this thing that we called APP-itis, which I think you probably figured out already is going to be something we called acute appendicitis. And once again, you have a lumen, you have some blood in it, you have a lot of lymphoid tissue, and you have the mucosa. And let's zoom in again on this muscle, okay? And we're going to make a little box right here in the northwest corner. And I'm going to ask you the same question that I asked you before. Are these smooth muscle fibers infiltrated by neutrophils or not? And the answer is yes. So that is the definition of acute appendicitis. That is probably one of the best, easiest ways for you to understand the overall architecture of inflammatory diseases. If these cells were neutrophils, you would call it acute inflammation. If these cells were mostly lymphocytes, you might call it chronic inflammation. So that's lesson number 1. Let's go to this third slide, which I think I want to call GBNL. And I think the slick people out there will recognize this is going to be a normal gallbladder. Okay. And remember, gallbladder is a classical example of beautiful single columnar epithelium. And then you have a little connective tissue, and then you have some muscle, and then you have more. It kind of follows the same general pattern as the rest of the GI system, but let's blow it up a little bit. You can see these beautiful linear palisading columnar epithelial cells. You can see some connective tissue also in the mucosa. And then you can start to see some smooth muscle cells. Now, you know the gallbladder has to have smooth muscle cells, otherwise it couldn't squeeze bile down through the ducts. And then you have some connective tissue around it, ultimately a serosa, because most of the gallbladder is also intraperitoneal. Now, let me ask you the same question. I'm going to go into the muscle, and I'm going to go through most of the wall. And I'm going to ask you, even though this is not perfectly in focus, maybe I'll find a place that has better focus. Like here. I'm going to ask you if you think that those smooth muscle cells are infiltrated by inflammatory cells or not. And look at this whole band here, no inflammatory cells, just the hot dog nuclei. This whole band here. So no, this is a normal gallbladder. This was even labeled normal gallbladder. And now that you generally have a picture in your mind of what a normal, non-infiltrated gallbladder should look like, we're going to go to this thing called GBitis, which you might think is acute gallbladder or chronic cholecystitis. And here we go. And now we could see some of the mucosa again, but we can also see that even from this power that the wall is not nice and uniform in pink. It's variable, and you can see part of the wall is thickened, and maybe part of the wall is edematous, and part of the wall may be hemorrhagic, the red areas. So let's look at that microscopically. Oh, I don't know, how about if we did something like this? We're going to the southeast and blowing it up. And I'm going to ask you the same question that I asked you before. Do you see a nice array of smooth muscle cells, like maybe there's a little piece here? Or do you see that the wall is infiltrated by inflammatory cells? And you know it's infiltrated. So whereas the other thing was a normal gallbladder, this is something that is infiltrated by inflammatory cells. Now, if you look at the inflammatory cells and blow them up, and you have determined that most of these cells are neutrophils, like you see here and here and here and here and here, maybe half of them, then you can call it acute cholecystitis. If your honest judgment feels that most of these cells are not neutrophils, but they're lymphocytes, then you could call it chronic. If you're not sure whether most of them, if there's an equal, more or less number of neutrophils and lymphocytes, then you are obliged to be honest, and you could say acute and chronic cholecystitis. And that's your final diagnosis, and it's correct. Now, I personally think if I did a count, I would say at least half of these cells are probably neutrophils because they look like they have lobed nuclei. And maybe a good number are also round like lymphocytes, like there and like there and like there. So if I wanted to call it acute cholecystitis, I wouldn't blame myself. If I wanted to call it chronic cholecystitis, I don't think that would be correct. But if I wanted to call it acute and chronic cholecystitis, that's what most pathologists would call it. Okay, so we're going to get out of that. We've already done 4 of them. Let's go to something called HTNL. So you think maybe that's a normal heart. And yes, what we're looking at is basically connective tissue again. You can see some blood vessels down here already. You can see there's some loose connective tissue that has a lot of fat. So maybe that is the pericardium, especially the visceral pericardium. And then you see some bands of some more connective tissue. Maybe these are papillary muscles or trabeculae. And let's just blow up any part of it because it all looks the same. Okay, so we're going to make a nice little box. So we're going to see a lot of cells. And these are all nice looking cardiac muscle cells. Now I know what you're saying, where you're saying, well, where's the striations? Well, you don't always see striations depending on the quality of the histology, but I'm going to blow this up a little bit more and maybe I can find you some striations. Now remember, it's easier to find striations when these fibers are cut longitudinally rather than cross-section. And up here, most of the cells are cut in cross-section. So I'm going to move to an area where the cells look a little more longitudinal, like maybe here, or here, or here. And I'm going to blow up this area here, and maybe we'll see some striations. And in all honesty, I don't see too many. But remember, you don't always see good striations on regular or even good histology. What is the bottom line? The bottom line is this is a normal heart. Well, you can say, what are those red things? Well, those red things are just blood vessels, okay? You remember the big blood vessels come in from the epicardial arteries that you have studied extensively in anatomy, and then they get smaller as they go deeper into the myocardium. And then at the most inner levels of the myocardium is nourished primarily by blood from the lumen of the myocardial chamber. So anyway, now that you got a good feel, once again, take a quick look with your eyeballs. That's a normal heart. So now that we've seen a normal heart, I know what you're expecting. Let's look at something called HTACINF. And you could probably guess that maybe that's going to be an acute infarct in the myocardium. Well, first of all, what you see is no longer uniform. You can see that there's some pink stuff out here, there's some blue stuff out here, there's kind of a ring of blue stuff. So you know this is not a uniform muscle like it should be, that there's some process going on here. And I'm going to blow up this box right here. And at the bottom, you'll see more fibers that don't look terribly bad. But what about this little edge here? I'm going to ask you once again, very easily, do you see all of those inflammatory cells that are infiltrating the myocardial muscle fibers? The inflammatory cells are chiefly neutrophils. And I know what you're thinking. You're thinking, well, there must be an inflammation. And yes, there is an acute inflammation, not because this is a myocarditis, but because this is an infarct in which necrotic fibers are now being chewed up by the inflammatory cells. It's the normal process. And remember, myocardial cells do not multiply normally. The ones you're born with are the ones you die with for the most part. They don't multiply. But what do you think would happen if this zone of dead myocardial fibers is chewed up by those inflammatory cells and myocardial fibers cannot come back again? Then you might see something like this. In other words, you are looking at myocardium again, but you're seeing pinker stuff down here and lighter stuff down here. So now we got myocardial fibers here, but what is this pink stuff down here? It's not myocardial fibers, it's fibroblasts and collagen. This is a scar. This is how myocardial infarcts heal, with a scar, fibrosis. These are all concepts we're going to go into in great detail in the next 2 webinars, which will be in 2 days, Thursday, as well as 5 days after that, which will be a week from today. So we saw a heart that was normal. We saw a heart that had an acute infarct with the inflammatory cells between the fibers. And now we see an infarct that you call old or healed, which could be months or even years old. So when you cut through a heart at autopsy and you see that there's a wider, grittier area than the normal thing, you might be cutting through scar tissue rather than through myocardial fibers. Okay, we're doing pretty good. And I have not been bugging you. Sometimes I'll ask you questions and I'll just look at some of your comments there, like yes or no. Let's go to, I don't know. Yeah, this will be a good one. This will be a good one. This is something you all feared in histology. And you might say right now, hey, what is this? But within a few seconds, you're going to see that its tissue has all of these glomeruli. So you already know this is renal cortex, okay? And you could see the glomeruli, and maybe you could see some blood vessels, but I'm having a hard time finding big ones. You could see tubules, proximal, distal, collecting tubules. Most of these things are proximal. And then the deeper you go, you're no longer going to see glomeruli anymore because you'll be in the medulla, which has primarily collecting ducts, but you're still like here. But basically you're seeing all the features of a quick normal recognition of a normal kidney. You're seeing glomeruli, you're seeing tubules, and I'm going to find you a nice fat blood vessel. Here we go. Here's a nice artery. This looks like it could even be possibly a segmental artery. It's pretty big. Here's another one too. So if you could see a normal arrangement of kidney histology with the 3 features, and they are not infiltrated or scarred or anything like that, and we looked all around the thing, then you're going to say, this is the world's most normal kidney. Let's look at a kidney again. And my God, it looks a lot more cellular than the other kidney. In fact, you don't even see much of the tubules, the lumen of the tubules anymore. So let's go to an area like this, a representative area. Yeah, you can still see glomeruli, but look at, most of the tubules are filled with inflammatory cells. And the inflammatory cells look like they are multi-lobed. I'll blow that up just to convince you. Most of the inflammatory cells, there's a glomerulus, by the way, but most of the inflammatory cells that you see within these tubules don't have a single round nucleus. They have a poly or lobulated appearance. So you know that they are neutrophils rather than uh, lymphocytes or macrophages. So we're going to call this pyelonephritis. And if most of these cells are neutrophils, would you call it acute or chronic pyelonephritis? Well, anytime you see neutrophils, of course, you're already getting it. You know it's acute. So that's a really good example. And of course, sometimes we can also see changes in the glomeruli on light microscopy, but most of the glomerular diseases have to be diagnosed by electron microscope. Some of them you can tell very easily on regular light microscopy. Okay, I think we're going to do maybe one or two more cases. Yeah, well, let's do a really, really good example of another major organ. It's called a lung. So I think you can see this little glass slide here under my virtual microscope, which is better than a real microscope, and it costs a lot less too. In fact, it was free. We're going to blow up this slide that says lung NL. And as you remember, if you see three types of holes in the histology of a lung, holes that contain blood, holes that contain air, and holes that are lined by epithelial cells, perhaps columnar or perhaps cuboidal. Here, we'll blow this area up. Then you have diagnosed lung normally. Notice the alveoli, the tiny little things with little septae, have nice air in them. This looks spongy. If you yanked this lung out at an autopsy and you squeezed it, it would be like a sponge. If this was filled with fluid, it would be foamy. If it had a tumor, it might feel solid. If it was a pneumonia, it also might feel solid. But look, here's a branch of a pulmonary artery. It's big. Here's your alveoli. And here's a bronchiole. Now we call it a bronchiole if it doesn't have cartilage. If it has cartilage, we call it a bronchus. So I'm going to ask you a trick question right now. Is this thing a bronchus or a bronchiole? Well, you're going to say, well, in most areas you don't see cartilage, but look, there's a little bit of cartilage there. I think you could recognize that instantly. It's still probably basically a bronchiole or maybe a small bronchus. The blood vessels have nice blood filled in them. This is not a clot. These are free-floating blood cells. And then you have a wide variety of alveoli. Take a quick picture in your mind right now. And forget about the names of all these damn cells. And know that this is a normal lung. And now we're going to go to this slide here. And maybe you didn't have enough time to see the label on it, which means you're not going to know what the diagnosis is from the label, but you are going to know what the diagnosis is from the picture. It looks like you have a lot of air spaces out here, and then it looks like you have connective tissue. So maybe these are two different lobes, or segments at least. These are probably two different lobes of the lung. There's a lobe of the lung that looks like it has normal air filling the alveoli. And then right next to it, through the major fissure, defining this lobe, you can see alveoli which look like they're filled with something, maybe fluid or cells. So that's why we have a microscope. Let's blow it up and see what it is. Oh my God, you have normal alveoli out here. You have some kind of fissure. You have another lobe here, and the alveoli within this lobe is filled with cells. And I want to ask you again, do you think that the majority of these cells have multiple lobes or a single lobe? In my opinion, I'm seeing the predominant cell here having multiple lobes. I know there's a few that have single lobe. Maybe they're lymphocytes or macrophages or what they call mononuclear cells. But what would you diagnose a lung in which the alveoli are filled with neutrophils? Please give me your whole diagnosis now. I want to see somebody really look smart. You call it an acute pneumonia, don't you? And furthermore, because this pneumonia seems to be limited perhaps to this one lobe with another one there, you might call it a lobar pneumonia. And there's basically two kinds of pneumonias. The ones that involve a whole, perhaps individual lobe, which is a lobar pneumonia, which is the most common type of pneumonia, which is streptococcal or pneumococcal pneumonia. And then most of the other pneumonias, which are much more common, they start from the bronchus, the inflammatory changes, and then they spread into the non-bronchial or alveolar parts of multiple lobes. That's called a bronchopneumonia. This was labeled acute pneumonia, and that's probably what it is. Now let's see if I want to show you something else or not. Yeah, I'm going to show you one more thing before I let you go. I think you've had enough torture already today. I'm not going to show all the cases, but I want to show you one real nice case. And I think you're going to get this right. Here's a lung again. You could instantly recognize that because you see all those air spaces. But look, you see a big nodule within the lung. And you probably even felt that nodule when you were the surgeon or the radiologist or the pathologist. And as a pathologist, you get the chance to actually put it under the microscope. And would you say that almost all of those cells are irregular glands? Does anybody want to make a diagnosis? So far, most of you have been pretty bold and very correct. Well, somebody said adenoma. That's a good possibility. Somebody said metastasis. That's also a good possibility. But if you look at the glands and you agree that they are very haphazard, and some of them look like they have an increased number of mitoses and they abut on each other, and you are convinced, or I have convinced you, that this is an adenocarcinoma, although somebody might call it an adenoma, you then ask yourself, did this adenocarcinoma start in the lung, or did it metastasize to the lung from a glandular organ like the prostate or breast or colon or pancreas? So let me ask you this question, and it's a trick question, because I'm going to tell you, I'm going to scream at you and tell you that you're all wrong. Did this adenocarcinoma start in the lung, or is this a metastatic adenocarcinoma to the lung? Well, somebody already got a right diagnosis, and because almost all of you are saying metastatic, and you're probably right, but you can't really tell that just on the basis of the morphology alone. If there were 30 more nodules like this in the lung, and clinically the patient had a pancreas carcinoma or a colon or another glandular organ with a malignancy like a breast or a prostate, then you could say it's probably metastatic. But all you could really say honestly is that there is an adenocarcinoma in this lung. That way you're not saying it started here, and that's the way you're not saying it metastasized here. So honesty is the big thing, because if you don't have honesty, you'll never have truth.